Thank you very much, Professor Nkwa, for having us here, and also those, the people who have put this great conference together. Mel, thank you very much for inviting us and having us here. Harvard University for having us here. Thank you very much for giving us the opportunity to join the great conversations on issues to do with health. As Mel has indicated, ours is two-legged stool with, I'll be speaking to issues to do with investment as and when such issues are raised. But with me here, Dr. Skipper, as has been indicated previously, Permanent Secretary, who has worked with World Health Organization, who has also worked with UNIDES, and whom I thought would be appropriate to speak to the issues from a very technical, both technical and policy related and dynamic. And Dr. Skipper, sir, thank you very much for listening.
Let me add my appreciation to the ambassadors for the opportunity to come and make this presentation. Do you have a microphone?
Yeah.
Okay, all right. As the ambassador said, worked in the Ministry of Health, is in various levels of the health delivery system, from a junior hospital doctor. I left when I was the permanent secretary in the ministry. Then I went wandering around the world, worked for UNAIDS, worked for various organizations, Family Health International. And currently I am a member of the Technical Evaluation and Reference Group of the Global Fund, and within the country I'm also a member of the Presidential Advisory Council. So I'm not sure how to navigate on this thing. Okay, so briefly, I will speak to a few of those topics. I'll quickly look at geographical context of this presentation, and we'll look at the demography. What does the population look like? And then we'll look at the epidemiology, and briefly look at the health delivery system and some of the challenges that we are facing as a nation, and then we'll address some of the potential and possibilities for investment in Africa. One of the themes that kept coming up in the earlier discussion was the issue of partnership. In this map, I was trying to show the geography of the area. What you have there is 14 countries that make up the SADC region. I deliberately put it there because of the potential importance of that regional cooperation, especially in the control of some of the non-communicable diseases that we will have to be dealing with. I mean, for instance, we have had an excellent collaboration in malaria. We are now currently looking at the possibility of eliminating malaria. And also, one of the key features of this regional grouping is that some of these countries have had probably one of the worst levels of HIV, but we are proud to say that we are now seeing some decline of that epidemic. And the other possibilities here are in the area of drug manufacturing. Normally, drug manufacturing would present a challenge if we were to just focus on Zimbabwe. But if you're looking at it from a regional point of view, it begins to make sense in terms of economies of scale. So that possibility is important. Zimbabwe, made up of 8 provinces, rural provinces, and 2 metropolitan or urban provinces. So, not sure. Okay, just a brief summary on some of the geographical features. The country has access, very good access to seaports. We have from Durban in South Africa, Beira in Mozambique, and Wolves Bay in Namibia, and an excellent transportation hub with daily and frequent flights to South Africa, Dubai, Kenya, and other countries in the region. We have a fairly decent road infrastructure that makes it possible for the transfer of goods, but also the movement of people that impact on the epidemiological dynamics that you see in the region. And I mentioned there the climate change resulting, some of the things that were mentioned earlier on, the cyclones, Itai, Kenneth, and that, for me, highlighted the need for the importance of regional collaboration when it comes to disaster preparedness. And clearly, these two happenings showed us that we are not great in terms of being prepared. So that's an aspect, I think, of non-communicable diseases that will need to be addressed as we go along. And we have also had some droughts that impact on food production. So I think as we go along in healthcare, we need to think beyond just healthcare, but also the climate changes. So bit of demography there for Zimbabwe. Population 17 million based on the 2012 census, and the majority of the population lives in rural areas, 67%, and predominantly female. 50% of the population is female, and 48% is male. And I specifically talk about the number of households. This has an impact on some of the disease controls that we'll look at later on. I'll speak to that when it comes to community health services. Total fertility, 4.3, and the population is estimated to be growing at 2.7 per year. But one of the features that's important there is the fact that that population is also aging, which is going to bring some certain dynamics on the epidemiological pattern. So although significant progress has been made over the last few years in the country, but we still face those infectious diseases or communicable diseases. And we have diseases or conditions that have to do with the reproductive health system. So, and now we have a fast rising non-communicable disease situation that is quite worrying. In fact, some of us are beginning to think that there is a silent epidemic of non-communicable diseases that probably may be worse than the HIV epidemic. Yes, HIV was very visible, but this silent epidemic, we're not seeing it, but it is rising. Prof. Anyong, you mentioned the fact that you have been diagnosed with this with cancer. I have a group of friends. There's about 6 of us. These are high-level people. 2 of them were working for the United Nations in New York. One was working for the World Bank. I've been all over the place. The 6 of us, all of us, are being treated for cancer. Fortunately for us, this group, with the exposure that we've had, I get treated in the US, and some of my colleagues are treated in the US. But how about the many other Zimbabweans that are out there that are having similar problems of prostate cancer? I know what's happening with them. I'm seeing them dying. Past couple of years, the number of friends of my wife, young ladies that have died of cervical cancer, breast cancer, is frightening, and you wonder where we are going. So, added to that, those in the region will tell you we now also have other rising infectious disease, cholera, typhoid, and the diarrheal disease. Things that should have gone are coming back, sometimes coming back with vengeance. Only a couple of years ago, Zimbabwe had a cholera epidemic which claimed the lives of over 4,000 people. I mention these things because of the need for collaboration, not just on direct health issues, but on things like water and sanitation. So, now what? So let's talk about some of the non-communicable diseases. Hypertension and cardiovascular diseases. A study done by WHO and the ministry in 2005 showed that 27% of the adult population actually had high blood pressure, 27%. And high blood pressure or cardiovascular disease responsible for 9% of the annual deaths. Diabetes. That study, same study, showed that 10% of the population had diabetes, and diabetes was responsible for 1% of the deaths. And then cancer, a variety of cancers. We are seeing an annual incidence of 5,000 new cases per year, and the death rate is 10%. These are the traditional classical non-communicable diseases, but we are also seeing something else. Injuries. Sometimes they are not mentioned as often as we should be mentioning them, but I live there most of the time, and just in the first quarter of this year, the number of bus accidents that claimed literally hundreds of lives is indeed frightening. And that requires some degree of collaboration in road construction, road safety, and that will need to be addressed. And then we have other diseases, oral health, eye diseases. And then the last group there in blue, these are things that may not be very loud in terms of causing death. Things like cleft lip, clubfoot, fistula, not many deaths, but the cost at personal level in terms of social impact is massive at the individual level, and yet these are things that could be addressed very effectively if we put in place systems for picking them and dealing with them through simple surgeries. So some of these things, although they're not receiving the attention that HIV and malaria may have had, they have a big social impact. So, brief look at the health delivery system. Like Mali, Kenya, and other countries, we have a multi-tiered health delivery system with central hospitals, provincial hospitals, district hospitals, and the primary care level. The government of Zimbabwe, having now realized that that health delivery structure will not get us to universal health access. A cabinet decision has now been taken to expand the primary level by inserting another level, what we're calling health posts. And the government has decided to put in excess of 5,000 health posts. These are small facilities run by one or two nurses, but embedded within the community with the nurse working with community health workers, we believe that that should bring us to a stage where it is possible for every person within a village in rural health, in rural settings, in urban settings, to have the possibility of having their blood pressure checked, to have the possibility of their blood sugar checked 2-3 times a year, so that we can pick these things early and start acting on them in terms of advice. What are some of the challenges that we are seeing in the health? One is infrastructure. We have, as I said, hospitals, primary care facilities. However, this is not getting us to where we are supposed to be in order to pay full attention to this emerging epidemic of communicable disease. So we believe that that's a potential for collaboration, building this health policy. I understand that in this country, there is now technology and capacity to build some of these structures using modular structures. So that's a possibility of infrastructure. Equipment. We talked about the difficulty of diagnosis, early diagnosis and early intervention. This last week, the 2 radiation therapy machines that we had in the 2 central hospitals broke down in the past week or 2. Translate, what does that mean? All the people that have been having that treatment, women who have been treated for cervical cancer, women that have been treated for breast cancer, are facing a threat of dying. What I find sad about that scenario is the fact that on one hand, we have General Electric sitting here, manufacturing these things, dying to get them out there. And we have the patients sitting in Zimbabwe, in Mali, in Kenya, dying for the machinery. We're not making these 2 things meet. We need to find ways of meeting this. And I guess it's a win-win situation for everybody. General Electric manufactures these things, puts them out there, maintains them, and the patients get treated. Women survive, look after their babies, look after their families, but for some change, we're not making these things meet. Small medical equipment. We talk of high blood pressure, but you go to some of those facilities today, health centers, hospitals, that may have 1 blood pressure machine that circulates among the departments, yet there are companies that are manufacturing these things here and elsewhere, dying to market them, and can't measure blood pressure of a woman who is pregnant during antenatal care. So there's something wrong there, so we need to figure out how to address these things. We have serious shortages of manpower. Here we are looking at clinical specialists, we are looking at nurses, at pharmacists and paramedical staff. And one of the things sometimes that we forget is the fact that health is not just about all these technical people, the clinicians. The element of leadership and management, I think, is something that requires to be addressed if all this investment that we're talking about is going to make sense. We need people that can manage, people that can plan ahead and make sure that the investment is being put to good use. ICT, it is theoretically possible now, today, that a community health worker can actually screen the BP, and can take blood sugar, and that result reflects in Harare, and that person can get advice through, I don't know whether it's e-health, m-health, but we have the capacity, we have the capability today through technology to bring specialized healthcare to the village without getting into the bus, which comes once a week. So the issue of health financing, very important. My colleague from Mali mentioned about free healthcare. Free? Not so sure, it's not free. Somebody pays for it, the government pays for it. But at the moment, the truth is that most of that financing is done from out of pocket. That's problematic. So we need to figure out ways of coming up with financing schemes. And it seems developments are showing that it is possible. Rwanda now is at the forefront of coming up with a community-based health insurance. I'm sure if we were to put together all the clever guys from the World Bank and that, we can craft a health insurance scheme that can address some of the practical realities of countries where there is high levels of unemployment or informal sector employment. So, happy to say that, okay. I will let the ambassador later on speak to the government of Zimbabwe commitment to universal health care, where some of those things are embedded within the constitution. We have a serious approach at the moment of decentralization and devolution, and some of the, we have recently developed a community health strategy, and we copied it from Kenya, and we are developing an essential health package. So, then we have a policy that addresses the issue of public-private partnership, and an act of parliament that actually addresses the issue of public-private partnership, and a whole unit that is responsible for coordinating that. And the opportunities for collaboration, several opportunities that we hope that we'll be able to talk about. Too long.